Hello, my dear students. I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. Today I have brought to you a series of lectures which are about inguinal region, anatomy of inguinal region. So here I'll be teaching you anatomy of inguinal canal, how to draw the inguinal canal. I will also take you through the anatomy of direct and indirect inguinal hernia. Today we are discussing anatomy of inguinal canal. The links for the other 3 lectures are given in the description section. I strongly advise you to watch all these lectures together. This lecture, I think, is not only for an MBBS student who is studying anatomy, but also for an MBBS student in the final year when they are trying to study surgery. It's also for students who are already doing post-graduation in surgery to brush up anatomy of inguinal region. I hope this really helps you students. This is a topic that is so oft discussed. Okay, so this is my contribution to your studies. Let's dive in. Okay, anatomy of inguinal canal. This is part 2 of the lecture on inguinal canal. The link for part 1 is given in the description section. Students, in my earlier lecture, which was Inguinal Canal Part 1, we introduced the Inguinal Canal and discussed its boundaries such that we imagined our Inguinal Canal to be a longitudinal rectangular cuboidal structure. Then we discussed in relation to this, as seen here, we discussed its anterior wall, its lower end, its posterior wall and its upper end. In today's lecture, we will be discussing the roof of the Inguinal Canal and the floor of the inguinal canal. We will also learn to draw the inguinal canal so as to understand the roof and the floor better. We will discuss the contents, the defense mechanism of inguinal canal, and finally, of course, we will discuss the inguinal hernia, direct as well as indirect. So let's begin. As usual, a request, please sit with color pencils, drawing implements, so that when I ask you to draw, please do draw. Believe me, drawing helps you to understand and recall way better. We have finished the posterior wall and the upper end. Now what do we do to understand the roof and the floor? Correct? You have understood the posterior wall, you have understood the upper end. Now what you need to know is superior wall and the inferior wall, that is roof and the floor. For this, I want you to develop this diagram. Okay? So students, take your color pencils and let's begin our diagram. Ready? Students, the concept of roof and floor of inguinal canal is best understood by drawing. Take a black colored pen and first draw the abdominal wall, the superficial fascia that lies immediately deep to it. Draw it nice and thick, student. You can also use a pen to draw the second layer of superficial fascia that is inside. Draw your external oblique muscle. See how in the lower part the fibers curve inwards. These curving fibers that you are seeing, these are the inguinal ligament. This is your internal oblique muscle which close to the inguinal canal curves in this manner. This is your transversus abdominis muscle which again close to the canal curves in this manner. Both the muscles unite posteriorly and medially to form what is called as the conjoint tendon. Now this is your conjoint tendon, and this space that you are seeing here is called as the inguinal canal. Just for your pleasure, I am going to add the contents to it. This is the spermatic cord in case of males and the ilioinguinal nerve. Okay, let's add the fascia lata to this, which gets attached normally to the inguinal ligament. Okay, somewhere here is the pubic bone giving attachment to the inguinal ligament. You should add that. Okay, and this here is the fascia transversalis. Behind that here is the extraperitoneal tissue, and finally the peritoneum. Now look at the diagram to understand structures forming the roof. You can clearly see how the roof is formed by curving fibers of internal oblique and transversus abdominis, and the floor is formed by the curving fibers of inguinal ligament. Of course, the floor is also formed by lacunar ligament, but that's one small detail that you can learn upon your own. This simple diagram shows you the roof and the floor very easily. It also gives you a better understanding of what is inguinal canal. So as you saw in the diagram, the fibers of internal oblique and the transversus abdominis were passing over the inguinal canal, forming the roof. These fibers meet posteriorly to form the conjoint tendon. These are the fibers that form the roof of inguinal canal. Who forms the roof? The curving fibers of internal oblique and transversus abdominis, which curve over the canal, form the roof of the canal. To understand the flow, we use the same diagram. Go back to your diagram. Did you see how the external oblique fibers curved in this manner, forming the inguinal ligament? So the floor is formed by curving fibers of inguinal ligament. Okay, but let's take one look at this additional diagram here. Inguinal ligament here you can see gives rise to a triangular projection which is called lacunar ligament. So the floor is formed not only by curving fibers of inguinal ligament but also by the lacunar ligament. Two structures forming the floor, two structures forming the roof. Roof formed by curving fibers of internal oblique and transversus abdominis. Floor formed by curving fibers of inguinal ligament and the lacunar ligament. Right. So what have we covered? We've covered anterior wall. We've covered posterior wall. We've covered the roof and the floor. We've covered the deep inguinal ring and superficial inguinal ring. Thus, we have the anatomy of inguinal canal in place now. Okay. Just remember the contents are different in the male, spermatic cord and ilioinguinal nerve, and in the female, round ligament of uterus and ilioinguinal nerve. Common factor, ilioinguinal nerve. Now, question is that what prevents structures from passing through the canal? Canal to hai, it's already there. What prevents structures from abdominal wall from passing through the canal and causing hernia formation? Let's understand. This is called as defense mechanism of inguinal canal, comes as a short note very often. Use your hands, all of you. The canal is oblique. Some structures are posterior, some structures are anterior. In case the pressure of abdominal contents increases, the two structures just become flush with each other. They become just fused or abut each other in such a way that they do not allow structures to pass through. This is flap valve mechanism. Each of the openings, like I told you, superficial inguinal ring protected posteriorly by reflected fibers of inguinal ligament and conjoint tendon. Deep inguinal ring protected anteriorly by the internal oblique. Each opening is provided with a protection. Okay. Now, there is something called as a shutter mechanism. Do you remember in shops, sometimes you have this shutter which they pull down. I put an image here for you to understand. So what happens is this, if this is your canal here, your conjoint tendon fibers are curving over it in this manner. When they contract, they just drop down on the canal from above like a shutter, closing it off. No abdominal content can pass through easily. This is called as shutter mechanism. Do this once. This is your inguinal canal. These are your curving fibers of internal oblique and transversus abdominis when they forming conjoint tendon. When they contract, they just shut down in this manner, like a shutter coming down, okay, preventing herniation. Ball valve mechanism, the cremaster muscle causes the testes to get pulled up to the superficial inguinal ring, blocking it. Again, remember that it's an oblique canal. Contraction of muscles causes the obliquity to increase. If the canal is this much, when the muscles contract, the canal gets elongated. But as the canal gets elongated, it becomes narrow. The narrow canal does not allow structures to pass through. This is another mechanism of protection. So here you have external oblique and transversus abdominis acting in this mechanism. Let's revise. Flap valve, anterior posterior walls fusing together. Strengthening of openings, superficial inguinal ring, deep inguinal ring, protected by various structures. Shutter mechanism, conjoint tendon. Ball valve, testes coming and blocking superficial inguinal ring. An elongation of canal by action of external oblique and transversus abdominis, causing the inguinal canal to get elongated and therefore narrow. If it becomes narrow, no structures can pass through. These are protective mechanisms which are created in the body to prevent herniation. But both male and female human beings have a potential area of weakness in the abdominal wall, which is your inguinal canal, and this is why we suffer from inguinal hernias. Canal is, despite all this, a potential area of weakness. So what is inguinal hernia? We come to applied anatomy, last 2-3 minutes of the class. Inguinal hernia is a condition where abdominal content covered by peritoneum passes into the inguinal canal. This is inguinal hernia. What kind of abdominal content can it be? It can be intestine, it can be omentum, anything. It can also be Meckel's diverticulum, in which case it's called as Litter's hernia. Comes as a MCQ very often, please remember this. Right, let's come to this diagram which I didn't have time to explain, now I do. This is your anterior superior iliac spine, this is your pubic symphysis, that's your inguinal ligament. So, when a hernia passes through deep inguinal ring, it's called as indirect inguinal hernia. It will always lie lateral to the inferior epigastric artery. This is your inferior epigastric artery. Such a hernia will always be lateral to the inferior epigastric artery. 2. Here you can see a triangle formed here, right? This triangle is formed by lateral border of rectus abdominis muscle, inferior epigastric artery, and the pubic and the inguinal ligament. This is the triangle. If a hernia passes directly forwards through this triangle called the Hasselbalch triangle, then it's called as direct inguinal hernia. This will always lie medial to the inferior epigastric artery. So you have an artery. If the hernia lies lateral to it, it is indirect. If the hernia lies medial to it, it is direct. So these are types of hernia. We've just discussed what is inguinal hernia, what is direct and what is indirect inguinal hernia. More about each of these is discussed in separate lectures labeled as Anatomy of Indirect Inguinal Hernia and Anatomy of Direct Inguinal Hernia. Link for both these lectures is given in description section. Interested student therefore should attend all these lectures to thoroughly understand inguinal region. Thank you students. I hope you enjoyed this lecture. I am requesting all of you to like and subscribe to my channel. I'm also requesting you to write some comments. Are you enjoying lectures? What do you want more in this lecture? It would really help me to provide you with better and better lectures and help you to study your subject of anatomy. Alright students, I had a great time taking this lecture. I hope you enjoyed it too. See you across the screen in some other video. Bye.